about in melanoma, like BRAF mutations and immunotherapy that are applicable to lung cancer. And you'll also see things like the epidermal growth factor receptor and HER2 that are also applicable in lung cancer. So what I'm saying is some of the knowledge that you already know and have and possess, you'll see in application today for non-small cell lung cancer. So maybe what we'll be talking about is the different types and how genetics apply to the different types and how the genetics of those somatic mutations apply to what particular type of drug that patient will be receiving or could be eligible to receive. Here is a lot of molecular biology information as it applies to non-small cell lung cancer. Some of this is important, some of this is less important. So what this table is showing is all of the different possible mutations, not all of them, but a lot of different possible mutations that we might see in the molecular biology. If it's in green, it means that there is a drug approved, for example, for an ALK rearrangement in the gene, or a genetic mutation in EGFR, epidermal growth factor receptor. And there could be drugs approved in other types of cancers that may apply here. For example, BRAF mutation, which we saw in melanoma, HER2 mutation, which you see in breast cancer, MEK1, which we see in melanoma. We haven't talked about a rearrangement, but also as it applies to drugs in non-small cell lung cancer, we have a ROS1 rearrangement. And so we're going to talk about these drugs for these mutations today in this lecture. We'll also touch on some of the companion diagnostics that are available. What's interesting to me too about lung cancer is it's always changing. We always have new drugs for ALK rearrangements. We're having constant approvals. In fact, I'm going to mention a drug that was approved just Friday, November the 2nd. I don't have a lot of information on it, but I am going to mention it just to be comprehensive as to what's out there in the new formulary. We're always seeing companion diagnostics added to the profile of different FDA approvals in different ways that you can check the somatic mutations of tumors in patients to see what's altered and what could be applicable for that particular patient. Never smokers are those that are most likely to have adenocarcinoma. So adenocarcinoma comprises the bulk of the 3 different types of non-small cell lung cancer. And if we have a never smoker with adenocarcinoma, these patients have the highest incidence of mutations in the epidermal growth factor receptor, HER2, ALK, RET, and ROS mutations. These patients will also do the best overall. So in addition to surgery, radiation, there's a lot of different drug therapies that apply to this class of patients and not other patients for reasons we don't quite understand. I mean, we do understand that the reason they have lung cancer is not due to the fact that they're smokers because they don't smoke, but we don't understand what other factors are they being exposed to, or maybe they have genetic susceptibility to that causes these mutations that goes on to develop cancer in some and then cancer and not in everybody. And we could see altered gene, we could see a profile that includes altered mutations in the FGF receptor, the fibroblast growth factor receptor 1, NRF2, AKT, or PIK3CA. And if we see this profile show up, then that is most likely a patient with squamous cell carcinoma. That would be important to know too, not only the type of drug that they might be eligible to receive, but what type of cancer are we dealing with? Yes, a pathologist is going to have information to that regards, but if the genetic profile lines up with the pathology profile, then we have a more definitive diagnosis. We know how to handle that patient. This would be in comparison to if we have a non-small cell carcinoma that's squamous versus a small cell carcinoma, the drugs that they're going to get are going to be completely different. So that information is just as useful. So on your quiz today, I won't only ask you, what type of drugs they'll be eligible for, but what type of cancer do they have based upon this information. And here we're looking at a formulary for agents that could be used in non-small cell lung cancer. We have the chemotherapy, which we call the traditional cytotoxic, sort of the original and older classical way of treating patients. And then we have the newer way of treating patients. So everything I have here in green is an EGFR inhibitor, whether it's a small molecule inhibitor or a monoclonal antibody. We have a new addition to the formulary recently, decametinib, as an EGFR inhibitor. And then, as I said, we have 4 ALK inhibitors that are on this list, and then there's one addition. I'm going to make this a color in orange to match with my schematic for ALK inhibitors. So the first in class was crizotinib. Then we had the Me Too drugs, ceritinib, alcitinib, brigatinib, and now we also have leratinib. And again, I'm giving this to you to be comprehensive. Leratinib. And so leratinib was approved on Friday, November the 2nd. And we'll talk about how it fits into the ALK inhibitors, because they're not all designed for first-line patients. There is sort of a method to the madness, at least now, in terms of if you have a new drug coming onto market that's going to compete with these other drugs, you're probably not going to get those first-line patients. And so your initial approval might be a second line or a third line before you get to or have the opportunity to be tested to move up in the rankings. We also have angiogenesis inhibitors, but of course these are largely used in combination with other drugs for a lot of different types of cancers. And then we have the inhibitors of the immune checkpoint. So these I mentioned in melanoma as well. They're a little bit targeted in terms of when you're looking at the amount of PD-1 expression. There was that histology test that I showed slides of whether it was less than 0% of the tumor section had expression of PD-1, or whether it was 1 to 49% or more than 50%. And based on the expression of PD-1, you're going to see a correlation with how these patients respond to this drug. There is one that I didn't talk about in melanoma because it's not approved in melanoma, that is approved specifically for non-small cell lung cancer, and that's atezolizumab. It's a newer agent, and I will mention this, I think, in the last slide that I have that we'll talk about today. And as I previously stated, we do have companion diagnostics, lots of different ones for non-small cell lung cancer, and in fact for many different types of cancers. We just have thousands of these things hitting the market. So one example here is the Oncomine DX target test. So this is a qualitative in vitro diagnostic test that uses targeted high throughput parallel sequencing technology to detect SNPs, so a single nucleotide polymorphism or variant, and deletions in 23 genes from DNA and fusions in ROS1, which ROS1 you're only going to see in like 2 to 4% of non-small cell lung cancers. Not very common, but again, when you have a very targeted drug to go after that mutation, patients that have it will do really well and they'll respond to it. So for example, if we ran a test and it came back positive for ROS1 fusions, that would tell us then that that patient is eligible for the targeted therapy crizotinib. And previously we talked about BRAF and BRAF mutations V600E, and they would be eligible. In this case, this is the test for dabrafenib or trametinib, but we also know that we have encorafenib and we also have vencorafenib for this as well. And then other types of exon deletions. In this case, we're looking at ERISA. And then down here, these mutations, for example, if we see PIK3CA, we see this nucleotide shift. This wouldn't necessarily tell us exactly what drug to use, but it would tell us that this patient is most likely squamous cell carcinoma, because when we look back at this table, we're seeing right here, the altered genes, in this case, are most likely going to be small cell carcinoma. So here it is on the pie. I know it doesn't look like a lot, but if you have a mutation that doesn't show up very often, that can be an indicator that when it actually does show up, that's what you have. Here is the targeted formulary for metastatic small cell lung cancer, and what we're looking at here are these evidence blocks. And we're also looking at, in cases of advanced or metastatic non-small cell lung cancer, these are the evidence blocks from the National Comprehensive Cancer Network, looking at first-line therapy for somebody with an EGFR mutation. After first-line therapy, if they go on to have tumor regrowth and tumor progression, then they could be eligible to receive other subsequent therapy, depending on what somatic mutations arise in the tumor after drug resistance. However, if they have ALK rearrangements, we've got some first-line therapy, we've got subsequent therapy, and now we have a third-line therapy, and the third line is lorlatinib. So the reason why I say lorlatinib is third-line therapy is because what the indication said was that after patients progress on crizotinib, so that's first, and then they have to progress on either alcitinib or ceritinib. So this would be like step 1, step 2, whether they're given alcitinib or ceritinib as their subsequent therapy, then they're eligible, and that's the indication for lorlatinib. Once patients have progressed on crizotinib and then either progressed on alcitinib or ceritinib, then they're eligible for lorlatinib. And of course, they have to have an ALK positive mutation, they have to have advanced or metastatic non-small cell lung cancer. So I'm assuming this, but it's, again, third line, at least initially. Now, what the challenge is going to be for lorlatinib is to start to go head-to-head against some of these other agents to see if it performs better in clinical trials and whether it can move up further on that list and then make a larger impact in the market and possibly bring in more revenue for that particular company. Then we have the ROS1 rearrangement positive. First line would be crizotinib, and if we do see a BRAF mutation in a non-small cell lung cancer, that might not be that standard, but if it does show up, we know that we have drugs that can target that mutation in BRAF. And then we have our immunotherapy, if we have PD-L1 expression positive, first line, pembrolizumab, atezolizumab, or nivolumab. What I do like about these evidence blocks, I'm not sure if I've gone over this previously, so I just want to mention it here, is this is something new that the NCCN is doing to try to help clinicians and healthcare professionals be able to compare different therapies, and why would I use one over the other in terms of a hospital or a clinic is trying to establish what their particular protocol is for treating cancer patients. And so the evidence blocks have information about the efficacy of the regimen from 1 to 5. And for example, a 1 for efficacy would mean that this is palliative. It only provides symptomatic benefit. 2 would be it's minimally effective. 3 would be it's moderately effective. 4 would mean this is very effective. And very effective in cancer is interesting because it means cure is unlikely, but sometimes provides long-term survival advantage. So when you're dealing with cancer and cancer drugs, you really kind of have to wrap your mind around the fact that the way they are scored is not a very high bar. You're looking at cure is unlikely, but it's still considered very effective, according to the field. Now, you rarely would see something in this block 5, but if you did, that means that it's highly effective and cure is likely. It often provides long-term survival advantage. Then we have our safety, our quality of evidence, our consistency of the data, and the last is affordability. And so these are the two that I highlighted for this group as far as being pharmacists, the efficacy of a regimen, and the affordability of a regimen. So 1 would be very expensive, 2 would be expensive, 3 is moderately expensive, 4 is inexpensive, and 5 is very inexpensive. You're rarely going to see these for cancer therapy. Sometimes you're going to see down here with the first block shaded in because a lot of these newer therapies are very expensive. Some of the small molecule inhibitors for lung cancer are similar to other indications where you're looking at maybe $7,000 a month up to $15,000, and then some of the immunotherapies, those are under $12,000 a month, usually with a price tag of $150,000 per year per immunotherapy, at least as a list price. So when we're looking at the EGFR formulary for lung cancer, we have a number of drugs that are grouped into 3 different categories, and I'll go through these categories. But we have our traditional small molecule inhibitors, gefitinib, dacomatinib, erlotinib, and afatinib. And then we have the drugs that we would use if and when resistance developed. It would likely be osimertinib. And then we have nactuzumab, which is a slightly different type of non-small cell lung cancer, a little bit more specific. And then our traditional monoclonal antibody, traditional meaning it was the the first, and that is cetuximab. So targeted therapies for non-small cell lung cancer, what they're doing is they're inhibiting the intracellular kinase domain. And I assume this is probably a reiteration for this audience, and that you know this. You know that afatinib, erlotinib, gefitinib, and now dacomatinib, this is their target, right? They want to inhibit the intracellular signaling portion of this receptor. When we look at these, any of these really can be first-line therapy, and when we look at the guidelines, they're pretty effective. Again, we have very expensive drugs, or what they're classifying as expensive drugs, according to these guidelines. And then over here, we have the monoclonal antibody, nectumumab and cetuximab, which again are these huge antibodies that are going to bind to the outside extracellular domain of the EGF receptor and inhibit it there. And then we also have subsequent therapy. So I'm going to just back up for a second and mention a slide on dacomatinib. So this was I thought until Friday, the only 2018 approval. I say only, but 2018 approval. And so what they did, knowing that they didn't come first, there are other EGFR inhibitors. When you're not the first to market, one of the best things that you want to do is challenge the others. And why not challenge the weakest link? And we all know that gefitinib is the weakest link. It was pulled from the market at one point due to its ineffectiveness in post-marketing surveillance. So dacomatinib went head-to-head with gefitinib, looking at progression-free survival. And that was masked by an independent review, and then the progression-free survival that was calculated by the investigators. So what they're doing now with anti-cancer therapeutics might be a little different than other clinical trials, I'm not sure, but they want the independent review boards to come in and review all of the data from the clinical trials. They've been burned in the past where some of the drug companies were saying that their drugs were actually better than they were, so they no longer trust the reviewers solely that are doing the data analysis and doing the experiments. So they have these independent review boards coming in. What I find interesting is every time I look at the data from the independent review boards, it's always better than what the investigators were looking at. So I think it's a good system for keeping them honest. Another thing to mention about clinical trials for cancer is that it is considered unethical to run a placebo in there without using some other drug. The reason for that is because it's a life-threatening illness, and that's where the ethics comes in. If you already have a drug approved for a patient population that has a life-threatening illness, what you want to do instead of placebo is you give them standard of care. And then you can have standard of care with your new drug or your new drug without that standard of care. And so that's why you're seeing these drugs head-to-head and you're not seeing a placebo. It's for ethical considerations. So here is the performance of dacomatinib versus gefitinib by the independent review board and then by the investigators themselves. And we see statistical significance, suggesting that these newer agents, even though they're late to market, they might be better in terms of the efficacy. So they're bringing something different and something beneficial to the market by showing them lead. And here is just a written out slide where I have specified what are the indications for the EGFR inhibitors. And I tried to be consistent with my color scheme here, where we have gefitinib, dacomatinib, erlotinib, and afatinib. And a lot of these are similar in terms of dacomatinib is first line for metastatic non-small cell lung cancer with EGFR exon 19 deletions or exon 21 L858R substitution mutations. So lysine and 858 is substituted for arginine. Similar for erlotinib, first line for patients with metastatic non-small cell lung cancer tumors with exon 19 deletions and exon 21 substitutions, or it could be maintenance. And so comparing these, there's not a whole lot of difference. So again, that's why the companies rely on clinical trials to show, okay, we're going after the same target, but my drug does it a little bit better than your drug and so forth. Having said that, because gefitinib is a little bit older, this is going to be the first one that's going to lose patent protection, which will be a huge cost savings for patients not having to pay $10,000 a month for their medicines, but it may not be better and have better efficacy than some of the newer drugs. But again, we're going to have 20 years of patent protection and continue to be very expensive. Now, what's interesting about non-small cell lung cancer, I'm going to move forward to this slide and then come back to this slide, is that what we know is that these patients are going to become drug resistant. It's almost like every other tumor out there. Tumors have somatic mutations that they acquire, but they don't stop acquiring somatic mutations. You hit them with a drug and their biological response is to survive and overcome that drug. So they're going to mutate again. And they already know how to mutate, right? This is in their repertoire. They've already tapped into these programs. And so most of the time, when it mutates in response to an EGFR inhibitor, it mutates by forming a new mutation, a threonine and 790 substitution for methionine. And so that's right here in the lobe where this mutation happens. And so that's why osimertinib is subsequent therapy, because patients with EGFR receptor mutant lung cancers eventually develop acquired resistance to first-line EGFR tyrosine kinase inhibitors. 63% of these, I know this says 60, but other sources say it's around that, but 63% have T790M changes in exon 20. This is going to inhibit those original drugs from binding. So those original drugs meaning, anything up here that was applicable. It's going to mutate. There are lots of different mutations that could happen, but most likely it's going to be this one. So what do we have to do again? We have to go back and test the genetics of that somatic mutation. So we're going to take a biopsy of that tumor, test it, and see, is this the new mutation that has arisen in that particular cancer? If the answer is yes, then we can go in and treat them with osimertinib. So this is indicated for EGFR T790M mutation positive somatic mutations. This was an orphan drug breakthrough status, top priority in 2015, because we did this, and this might still be one of the first drugs out there in cancer that does this, where you're predicting, we know it's going to be resistance, so when it becomes resistant, what's next? And if they have this somatic mutation, here's how we treat them. So hopefully we'll see more of these coming online because we know it's an inevitability. And then lastly, nectumumab. So this is a monoclonal antibody, but rather than compete with cetuximab and really compete where there's no market share, they went for a more specific type of non-small cell lung cancer. So the difference here is they went after squamous, which is interesting because this isn't the biggest group. The biggest group of non-small cell lung cancer patients would be by far adenocarcinoma. But knowing that adenocarcinoma was really filling up with EGFR mutations, ALK mutations, this is a different indication. So it's squamous. It's kind of unique, but again, unique makes it marketable and gives it a use and priority. And it's first-line treatment in that case, so that's pretty powerful as well. Okay, so that's what I meant by, I would go to this slide and then go back. So this slide just outlines what are the different indications, and this is hopefully a visual to just sort of elucidate why that's necessary and why that happens. Here's another visual to elucidate. If you have EGF receptor kinase domain mutations, you can have different types of activating mutations. And you'll notice in the slide that most of the mutations are going after exon 19 deletions or that lysine to 858 arginine mutation, because that together, these two will cover 85% of the mutations that are bound to happen with EGFR. So it doesn't cover 100%, but it covers 85%. So the most common mutations are targeted by those drugs. And then we know that primary resistance is going to show up at T790M. Maybe not as common, but second site mutations, again, about 60%, this says over 50%, 63% of the time is going to show up at that threonine 790 methionine mutation, that substitution there. And so that's the reason and the rationale behind using these particular drugs. And so again, this just elucidates this resistance. Can also happen to osimertinib. So you're coming in with this knowing that this mutation is developed, but eventually you're also going to have a loss of that one. Now, we do know where that mutation is going to happen. So expect to just see sort of a chain of these in the future if you go into this field in terms of what we do next. But right now we don't have approvals. And of course there are companion diagnostics to look at the mutations in these exons in terms of Where are they? What can we do? Some drugs have specific ones, so this is for Tarceva. In terms of how would we know to use it if we saw these specific deletions, and then again with osimertinib, we want to see this specific change after drug therapy. And so we have companion diagnostics that help us out and tell us what's going on in the cell, and then how to combat that. Now, usually it's going to take between 8 to 14 months on average for resistance to evolve. So that gives the patient about an additional year, but that quality of life during that 12 months can really be fantastic, kind of like we saw with the picture of the BRAF patient that had all these tumors and then took the vemurafenib and looked really robust and healthy again. Here is another type of companion diagnostic. Again, this is for gefitinib or afatinib in terms of, is the patient eligible for this? Well, there's companion diagnostics for that to figure out whether or not that would be approved. So we have a lot of different companion diagnostics. I don't want to just read and go through this slide. It's just to point out that there are different options depending on the type of drug. This is a reiterative slide. You guys should have received this from me before, but it's just reminding you that these EGFR inhibitors are great for the patients that have these mutations, right? They're very potent, but at the same time, the patients hate them and will complain a lot about them because 100% of these patients are going to have this rash. So this acne-like rash on their face and their chest. And this is similar in regards to the side effect of hair loss, let's say, with patients that are on chemotherapy. So this is something that affects their appearance and therefore affects their mind and what they think and how they feel they are perceived when they go out to the grocery store, whether that's real or not. It does affect their quality of life. The problem with any drug that affects their quality of life can also affect their compliance and their willingness to continue taking that drug. Which is a very serious conversation, knowing that these drugs at some point are going to become resistant to it. And so they really do need to stay on it. And if they don't adhere to that regimen, they could be speeding up that 8 to 14 month period by allowing the tumor sort of a period of freedom to survive and thrive and build up these mutations. And just to reiterate, this is an on-target effect. There's nothing that can prevent this. Of course, we can treat this with topicals, but this is a sign that the drug is working. It's an on-target effect. And this is just a reiteration of the genetic profiles by histology type, whether we have squamous cell carcinoma or adenocarcinoma. Now, notice there's a lot of gray in these pie graphs. And the gray, these are unknown. So a lot of these tumors, there are still a long ways to go in terms of research and really figuring out what's going on with these tumors, why do patients get these tumors, what kinds of mutations are we looking at, how can we target that? I feel like we're only really scratching the surface with a lot of these. But again, if you should see a profile, like let's say on your quiz, a profile of something like this, then you would know, okay, if those mutations are there, that means that this type of lung cancer is in play. Versus if you saw a mutation in ALK or an ALK rearrangement, that most likely would be a patient with adenocarcinoma. Again, for reasons we don't understand, a lot of times the patients with ALK rearrangements, they tend to be a lot younger. They tend to be non-smokers. We don't really understand why. They're almost always exclusive of EGFR mutations. And what happens with these ALK fusion proteins is we have an inversion of chromosome 2. So we have a piece of chromosome 2 that juxtaposes, inverts itself, and then inserts itself back into chromosome 2. This only happens in about 3 to 5% of non-small cell lung cancers, right? A very, very small portion. But when that happens, we have the creation of EML4, also known as ALK fusion protein. So it's literally called the echinoderm microtubule associated protein like 4 gene with the ALK, which is anaplastic lymphoma kinase gene. But we abbreviate everything, and so that's also known as, shortened as the ALK gene. But it's this chromosomal inversion, creates this protein that shouldn't be there. This protein just wants to create havoc, cause cell survival, tumor cell proliferation, tumor cell growth. And so these ALK inhibitors bind to this protein because it's not normally there. So by binding to it, you shouldn't be affecting anything else in that patient or in that tumor. You should really be able to very, very specifically target that tumor. And so crizotinib was the first in class to do that. And by doing that, you're shutting down cell survival, tumor growth, and tumor cell proliferation. Now, one interesting backstory of the ALK inhibitors is this was almost approved by chance, meaning that there was a clinical trial going on for non-small cell lung cancer, and there had been a targeted inhibitor designed for it. Gave it to 50 different patients, and in 49 of them, it did absolutely nothing, right? The patients are getting worse, they're getting sicker, so that clinical trial stops. But there's this one patient that has a complete 100% response on crizotinib, which was in clinical trial at that point. Complete response, right? No tumor, it's shrunk. And so they looked at that patient and they said, is this an accident? Is this a fluke? Or is there something going on? Sequenced those tumors, and that's how they put together what this inhibitor was doing and how it was targeted. But this wasn't necessarily done by sophisticated design in the beginning, and they had to go back and figure out what was going on. And of course, we have different companion diagnostics for ALK inhibitors. We have immunohistochemistry staining. This dark brown to reddish staining means that's positive, right? Typically, we would just see blue nuclei throughout the tissue if there was no staining. So this is a very, very positive sample for the ALK protein. And so that would mean that this would be between the 2 to 5% of tumors of non-small cell lung cancer that actually have ALK. So we have immunohistochemistry. We also have a FISH probe assay to detect the gene rearrangements involving the ALK gene. And so here is the results from FISH. And what you're looking at is red would be, one gene or one chromosome, green would be the other. And if you see yellow, that's an overlay between the two. So that's actually a positive hit, right? That's meaning you've got the fusion gene right there. So that would be positive for, yes, this patient has the ALK fusion gene. So what do we do with patients that have ALK rearrangements? As I mentioned, we used to have 4 drugs, but now, let me switch back to orange. Now we have 5. So I'm going to put leratinib down here. Now we have 5 drugs. Crizotinib was important because it was first-line therapy, first in class. Almost an accidental clinical trial, but very, very powerful drug. And so this was a similar story from Gleevec, where patients had a mutation, and they went from, hunched over in pain, crawling on the floor, to taking the medicine, walking around, feeling really, really good, and everything being a lot better. So anytime, I guess, you see a lot of different drugs still coming out for the same indication, mean that other companies want market share because this is a very powerful target, and bottom line is it works. Works really well, doesn't work forever, but I'll show some information on that. So second line approval was ceritinib, alcitinib, brigatinib, and now leratinib. Because we know that patients are going to eventually progress on crizotinib. It's a matter of time. So this is, just to reiterate, third line. As of right now, that's its indication. You have to fail crizotinib, and then you have to fail ceritinib or alcitinib. Why not brigatinib? Because this one was approved last year, and so I'm sure when they started the clinical trial several years ago, it just wasn't an option. So here is crizotinib going head-to-head against chemotherapy, because again, it's first in class. It was the first one that was approved, and so again, you don't want to do placebo. You want to go against chemo, which was the standard of care at that particular time. We're looking at progression-free survival. We see a statistical significance, and here we're looking at the probability of no deterioration in that particular patient, or patient population rather, and we see statistical significance. Down here, we're looking at quality of life indicators. So here we have improvement in quality of life and mean change from the baseline, and so crizotinib outperforms chemotherapy for nearly everything in this case. Here we're looking at ceritinib. So once crizotinib was approved, then of course other companies see the opportunity for market share. And so here we're looking at a waterfall plot. And I showed you what I consider to be beautiful waterfall plots for immunotherapy and melanoma, but this is even more substantial. So here's our 30% response evaluation criteria in solid tumors. And here are patients that are on ceritinib, which again was second in class. This was the Me Too drug. whether they had prior crizotinib treatment or no prior crizotinib treatment, they're still doing really, really well. And we have a portion of them that have just a remarkable response to it. Now, they do a little bit better if they have not had prior crizotinib treatment, but you still can give this to them for patients that advance. And again, here's baseline for the PET imaging and after 3.5 weeks. So what the goal was is then to say, okay, well, can we treat them with crizotinib, and then if they become resistant, can we switch over? And so that's exactly what happened. Here's baseline, here's the tumor. After 8 weeks, it's shrunk significantly on crizotinib, but after 34 months, which is almost 3 years, so that's really fantastic, tumor comes back. Then you go with ceritinib for 12 weeks, and then 15 months, it finally comes back. But again, you've added 4 years of life onto this cancer patient. That's almost something that's unheard of these days when we're starting to measure 15 days, 3 weeks survival improvement. So this is really incredible difference. And down here, this information is just showing that ceritinib is actually a better drug. So then comes to market alcitinib. And alcitinib comes to market with the premise that these drugs work, but what they're not doing is preventing metastases to the brain. So this is pre-alcitinib. And you see a nodular leptomeningeal metastases, an ALK-positive patient treated, and then after alcitinib. So alcitinib was really good at crossing the blood-brain barrier to prevent the growth of metastases in the brain. So that was really significant. And again, brigatinib was just so new that data was not reported. Don't panic, you don't have this slide, but I did upload the New England Journal of Medicine article to your folder, so don't panic. All I wanted to show is that brigatinib, being a newer drug, has to go against an older drug like crizotinib, and it's superior. This is similar to the gefitinib story with dacomatinib, where you're the last one to market, you have to challenge the first one to market because you need to be better. Otherwise, there's really no place for you and there's really no market share. And this is just about as beautiful as a waterfall plot gets in terms of the efficacy of these. So again, a good waterfall plot, you want to see a lot of water falling down. And these are just really gorgeous in terms of how many patients they can help reduce the lesions, a number of them at 100%. And lastly, I just want to mention atezolizumab. This is an immune therapy checkpoint inhibitor that is specifically approved for lung cancer. It does something a little bit different than nivolumab and pembrolizumab. So nivolumab and pembrolizumab are PD-1 inhibitors. They're going to bind to this receptor on the T cell to inhibit that interaction. Again, you want to come to the market with something a little bit different, so atezolizumab binds to the receptor that's on the tumor cell. So it binds to PD-L1. It's still inhibiting that same interaction, but it's going for the opposite receptor, so doing it a little bit differently, and this is its indication. Okay, so with that, I'm going to give you guys the password. It's crizotinib for the quiz today. You may do this open note. Please work independently. Open note, open slides, open everything. And it's crizotinib. And that's all we're going to do today. So after that, we're done. And we'll see you on Thursday. So it's crizotinib, capital C-R-I-Z